For today's lecture, yes, we have already told you about the pharmacokinetics. We have discussed absorption, distribution, metabolism, and elimination. We have discussed the core concepts in last two lectures. In today's lecture, we will basically focus how to basically measure different parameters of absorption, distribution, metabolism, and elimination. This will be the core focus or core. This is the core thing which we will discuss in today's lecture. So, in previous lecture, I have told you that pharmacokinetics is basically what whatever body does with your drug is pharmacokinetics, and it obviously include absorption. Basically, body absorb the drug, body then distribute the drugs to the different compartments, different tissues, different organs, and it metabolizes the drugs and then it eliminates and then it excretes the drugs. But in today's lecture, I will discuss pharmacokinetics is basically it is the quantitative measurement of absorption, distribution, and elimination. Because in today's lecture, I will focus more on how these parameters, for example, these parameters like how area under curve, how clearance, how volume distribution will be measured. That is why we will explain pharmacokinetics as a quantitative measurement of absorption, distribution, and elimination. Because in this lecture, we will focus more on how to calculate all these things, how we will gonna calculate different parameters for of pharmacokinetics. And as I briefed you in previous lecture, that we will focus more on the clinical aspect, whatever we have learned in these 10 years of whatever I have studied in these 10 years of uh, my clinical pharmacy experience. We will discuss more on these things. So yeah, I have explained you absorption in previous lecture that absorption is basically how much drug, yeah, how drug uh, go to the blood or absorb from your gut or from your lumen to your blood. The portion that goes into your blood is the absorption. But in today's lecture, I will explain it. It is basically the bioavailability. And what is bioavailability? It is the fraction which enters, the fraction of drug which enters into the systemic circulation. And it's basically determined by Cmax and Tmax. And what is Cmax and Tmax? I will discuss in later slides. And what is distribution? In previous lecture, I have told you distribution is how drug distributes from blood to different compartments of the body is distribution. But in today's lecture, we will discuss more about volume of distribution, how we will calculate volume of distribution, because volume of distribution is the main parameter which determines distribution. Then the next thing is metabolism. On has already discussed about metabolism, that how drugs transform through different hepatic enzymes, and then we will discuss in today's lecture excretion as well. In last lecture, which I have conducted, which was the first lecture of this series, I have explained you that excretion is basically how drug eliminates from the body, how drug eliminates from say liver, or how drug eliminates from the kidneys excretion. But in today's lecture, we will discuss more about the clearance, how we will calculate creatinine clearance, how we will calculate biliary elimination or biliary clearance, hepatic clearance, basically. So today's lecture will focus more on the calculation of these parameters. So these are the parameters: area under curve, clearance, volume of distribution, and we will discuss all these things in later slides. So the first parameter. First of all, I will explain all these topics, all these uh, concepts, and then I will explain it how we will calculate this. So first of all, the definition. What is Cmax? So yeah, what is peak concentration? It is the highest concentration of the drug which is measured in plasma. So basically, if you administer a drug and then we are as a pharmacist or our doctors are more interested in what is the maximum concentration of drug achieved in the blood. Why? Basically, let's take an example of vancomycin. If you administer vancomycin, which is an antibiotic, the minimum inhibitory concentration of vancomycin is basically 15 to 20. So at least your drug should be uh, should have a concentration more than 15 to 20. So it will be efficacious. So first parameter due to which we calculate Cmax is basically the efficacy, because we are interested in the pharmacological action of the drug. And then the second parameter is basically safety. Obviously, if the concentration of drug is more than a threshold, then it will have some hazardous effect. It will have some toxic effect. So there are two parameters due to which we are interested. First is efficacy and other is safety. And then we are also interested in the time to peak concentration. Basically, it is the time at which a drug uh, acquired peak concentration. If if a drug has more Tmax, it will have delayed onset of action, and if a drug has shorter Tmax, it will have rapid uh, mode of action or pharmacological action basically. And now, what is area under curve? And I'm just defining all these parameters. Then on later slides, I will calculate these parameters as well. No. Then what is area under curve? Area under curve is basically this is area under curve. It's a graph basically which we plot against concentration and time. What this area under curve explains, it explains everything. It explains what is the maximum concentration, what is the concentration in distribution phase, what is the concentration in absorption phase. I will discuss this area under curve in later slides as well. So it has clinical importance as well, because we calculate the dosing of vancomycin through this area under curve, and I will explain it in the later slides as well. But what area under curve explain to us, or why it is important for us, is basically it gives us overall pharmacokinetics of the drug. It gives us that how much drug is present at which time. For example, how much drug is present during its absorption phase, how much drug is present in the elimination phase. So area under curve is really important, and we explain it the total integrated area under the plasma concentration versus time curve. So this is something which is area under curve. I have shown. So we plot a graph between concentration and time, and we will in later slides I will show how area under curve will help us calculate dosing of different drugs, especially vancomycin. So another thing is bioavailability, and I have told you bioavailability is the fraction of whatever drug you have administered. The amount of drug which reach to the blood or which reach to your plasma is bioavailability. For example, a drug has a bioavailability of 70%, for example. So it means you have given 100 mg drug and only 70 mg drug reach to your blood. The other 30 mg is metabolized by liver, or your gut is metabolized in your gut lumen basically. So bioavailability is mean fraction, because this is the reason why we generally give this is the more core reason. For example, the IV dose of ciprofloxacin in 200 mg or 400 mg. But if you give any patient an oral ciprofloxacin, if its dose is 500 mg, because we know that the bioavailability of oral drug is less than the IV. This is the core reason. And how you have to calculate bioavailability is just area under curve of oral divided by area under curve of IV, because all IV drugs have 100% bioavailability, because you are administering the drug directly into your blood. And this is the core ADME basically, and you do need to understand that all these things, Cmax, Tmax, area under curve, and bioavailability determines the absorption of drug. And how it is determined absorption of drug, you will understand in later slides as well. So what happened is we give the drug. This diagram shows we give the drug, and then it goes to your gut. If it is an oral drug, basically, it will go to your gut, and then it will go to your plasma. Sorry, it will go to your plasma, and then it metabolize and then eliminate. And whatever unbound drug remain in your blood will bind to your receptor and will give its pharmacological action. So after absorption, you guys need to understand whenever we will talk about absorption, we will talk about Tmax, Tmax, area under curve, and bioavailability. But when we have to understand the distribution of drug, we will talk about volume of distribution. So what is volume of distribution? It is, and I should say, apparent volume of distribution. Because what is the volume of distribution? It is the therapeutic volume fluid which required, yeah, which contain your drug basically. No? Let me put it in this way that the concentration is basically is equal to the amount of drug divided by volume. Whenever we told the definite formula of concentration is basically amount divided by volume. But here there is a small limitation because you cannot determine the real amount of drug which reach to your target organ. For example, you are giving a drug which have, for example, you are giving an NSAID. An NSAID has to work on the cell membrane, and say it has to work on COX-1 or COX-2. So we cannot determine the concentration which goes to the cell membrane and work on that membrane on, and we cannot exactly determine the amount of drug which will reach to that specific receptor. So what we do is basically we administer a drug and we wait for the steady state concentration. For example, we know that after 4 or 5 half-life, for example, you are giving Panadol. Let's say I don't know about the half-life of Panadol, but giving you an example, you are giving an ABC drug and you know its half-life is 2 hours. And then I do know that after 5 half-life, you need to remember memorize this as well. That after 5 half-life, usually drugs have a steady state concentration. So what we will gonna do is we will take out a blood and of that patient, and we will ask a lab person to tell us the concentration of the drug. And then what we do, we will suppose we have given 500 mg dose, then what we will do is we will divide that 500 mg with the concentration. Uh, let's say the concentration is 1 mg per liter, for example. We will divide that drug amount with the concentration. Then it will give us the distribution. And what volume of distribution will give us? It will tell us that how much drug is present in your blood and how much drug is has leave the blood and went to suppose the different tissues. If a drug has a high volume of distribution, you can see in this present in this slide as well. If a drug has high volume of distribution, it means there is a less amount of drug is present in your blood and it has distributed to different parts of the body. It has distributed to your say brain, heart, or others. But if a drug has low volume of distribution, you have divided your whatever drug you have given. So, for example, you have given for 500 mg dose, and you have seen that the concentration has more in blood, so it means its volume of distribution is less. What it means? It means the drug has low volume of distribution. It is basically maybe it has bound with the protein. For example, warfarin is a drug which gets bound with albumin in the blood, so it has very low volume of distribution. So what apparent volume of distribution or volume of distribution tells us? It tells us that the drug is in the blood, or it has distributed to different compartments of the body. So volume of distribution tells us about the basically distribution, and other like bioavailability, area under curve, and Tmax, Tmax, they tells us about the absorption. And then clearance. Clearance is basically how much blood or plasma is cleared from the drug is called clearance. And we all know that there are two major pathways through which drug gets cleared. First is liver and other is kidney. So, and it is one more thing. Volume of distribution is important to calculate the loading dose of drug, and we will calculate this as well. And then you get to know that volume of distribution is really important when you have to think about what loading dose you have to give. But when it comes to maintenance dose, we are more so clearance is usually people think that clearance is basically how much drug has been exceeded. No, it is how much blood or plasma is cleared from the drug is clearance. That is why its unit is ml per minute, because our blood is whenever we calculate our blood because it's liquid, we calculate it in liter. No, so the unit of clearance is ml per minute. It means how much blood is cleared from your drug in how much time. That is clearance. So it is uh, uh, hepatic clearance is different, and there are different formulas to calculate hepatic clearance, and there is a different formula to calculate renal clearance, and we will calculate renal clearance and hepatic clearance as well. And you have to one more thing you have to, which I have told you, one more thing you have to memorize it. It is really important to calculate maintenance dose, and we will explain in later slides why it is important. So clearance basically depends on the half life of the drug. And what is half life? Half life is a time in which 50% of the drug get cleared from the plasma or the blood. So I have told you about clearance. It is really important to determine the dosing interval, and I have told you as well that usually drugs take 4 to 5 half life. That 95% of the drug gets eliminated, and it is the same half life after which drug gets a steady state. And I will explain the logic in later slides. And this is the formula of half life you have, which you have to memorize because we have to do certain calculations. Though I have written the same formulas before the numericals as well, but we have to memorize this, that half life is equal to 0.693 multiplied by volume of distribution divided by clearance. And then this is steady state concentration. So obviously, as a pharmacist or as a doctor, we are more interested that steady state concentration should be uh, maintained in the blood or plasma. Obviously, if you're giving an antibiotic, there are some antibiotics which are really concentration dependent. So if their concentration goes below a certain level, a certain minimum level, trough level, so there's a greater chance that the antibiotic will not work and the bacteria will have resistance. So yeah, we are interested. We are interested in steady state concentration for all the things, not for antibiotics, obviously. So it is the equilibrium state reach when you are repeatedly dosed, uh, whatever way you are dosing. For example, you are giving the drug orally or you are giving through intermittent infusion. After 4 to 5 half life, there will be a steady state concentration, uh, and you will understand the concept in later slides as well, because when I will explain how it happened. So key takeaways from this slide, from these slides is Tmax, AUC, and viability describes the absorption. Uh, Volume distribution describes the distribution of drug. Clearance and half-life determine the elimination. And please do remember that elimination means metabolism and excretion as well. Both are combined together to form elimination. And CSS is the target because in this state, whatever drugs goes in the blood, and the rate of input becomes equal to the rate of output in the steady state concentration. So yes, now what is this order kinetics? Uh, Now we need to memorize one more thing is that whatever chemical reaction is, whatever physical reaction is, there must be some rate of reaction. Like if you have studied any chemical reaction, there are some reactions which have fast rate, and there are some reactions which have slow rate. Similarly, every metabolic reaction, either it is absorption, elimination, whatever, all the metabolic processes have some kind of rate of reaction. So it can be zero order. What is meant by zero order? If any chemical reaction or metabolic reaction is not dependent on the concentration of the elements or the reactant, then it will be called as zero order. But if any chemical reaction or any metabolic reaction is dependent on the concentration of reactant, then it will be called as first order kinetic reaction. So first of all, we need to understand that absorption. Yeah, and I mean, it is recording. Uh, so we need to understand is absorption, metabolism, elimination. All these four parameters can be zero order, and they can be first order. Even they can be second order as well. And I will explain it later in this slide why they are zero or first order. But we are more interested in elimination. That is why in whatever pharmacology book you will explain zero order as if the amount of elimination of drug is constant, and the kind of elimination will be called as zero order. Uh, and then similarly, there are aspirin, phenytoin. These are the examples which follow zero order elimination. And similarly, there are drugs which follow first order kinetics. So they are concentration dependent, basically, like vancomycin, aminoglycoside, and the cephalosporin. What happens is the more you will give the drug, the more there will be an elimination. So they are concentration dependent. And You need to memorize one more thing as well. If a drug follows first order elimination, their half life will be constant. But if a drug follows zero order kinetics, their half life will not be constant. And these are the drugs like aspirin, phenytoin. If you give, let's say, aspirin has a dose of 300 mg when you have to give it as an antipyretic. Uh, Aspirin follows a zero order kinetics. The toxicity of the chances of getting toxicity with aspirin is more when you're giving it like 300 mg or 600 mg. There is more chance uh, you get a toxic reaction with aspirin because it follows a zero order kinetics. The more you give the drug, there is a more chance that the drug will accumulate in your blood because there will be less elimination. But in first order kinetics, the more you will give the drug, the more will be elimination. So first order kinetics is better. But and this is half life. I have told you you have to memorize these formulas: half life, volume of distribution, and clearance. Now, as I've told you, that not only elimination, even absorption can be first order or zero order. And first order absorption is really common because, like diffusion always depends on the concentration. And I have told you what is first order. First order is if any chemical reaction or metabolic reaction is dependent upon the concentration of the reactant, then it will be called as the first order reaction. So, as we all know, diffusion is when a drug moves from higher concentration to a lower concentration is absorption. And most of the drugs go through this path, therefore they follow first order absorption. But there are some drugs which follow zero order absorption. For example, there are many drugs which we administer through IV infusion. So it doesn't matter whatever concentration you have made, it will depend on the flow and not on the concentration. Similarly, there are drugs which are controlled release. Uh, these things are very important for the exams. You need to memorize it that all the extended controlled release drugs follow zero order absorption. Similarly, transdermal patches they also follow zero order absorption. Similarly, distribution also can be first order and can be zero order, because diffusion also takes place through diffusion, and diffusion is concentration dependent. But there are drugs which get transported into the cell and even out of the cell through some enzymes, some proteins, like P-glycoprotein. I have told you in last class that it is a transporter protein which is present on the cell membrane, and it basically uh, efflux the drug. It pump out the drug from the cell. So, but the elimination is zero order. It doesn't depend on the concentration. So, and then we have metabolism. So, metabolism can also be first order kinetics. Obviously, we have a lot of enzymes present in our liver. If you are giving any drug which concentration is less than the enzyme present in our liver, then it follows first order kinetics. However, there are three drugs like phenytoin, ethanol, and aspirin, PEA. You have to remember this mnemonic. These drugs follow zero order kinetics because the concentration of drug is more than the enzyme present in our liver. So it is basically, you can say, memorize it in the way that whenever the enzyme gets saturated for any drug, it will follow zero order kinetics. So for phenytoin, ethanol, and aspirin, the quantity of enzyme in our liver is less and the concentration of drug is more, therefore they follow zero order kinetics. So, and I have told you we are more interested in elimination. Elimination follows first order and zero order as well. Like for example, glomerular filtration. If any drug is hydrophilic, it will filter from the blood into urine, and then there are some active tubular secretion transporter proteins present in our nephron, and they basically transport back our drug. So they follow zero order excretion. Okay. Now you need to memorize this. Generally, our body follow first order absorption, distribution, metabolism, and elimination. There are many, however, there are instances where drugs also follow zero order kinetics, but unless it is written in your label, in your drugs manufacturer label, that it is zero order, otherwise you have to presume that the drug will follow the first order kinetics. Now, so this was basically the second section of my uh, uh, presentation. I'm now moving to the third section because I have divided whole of my presentation in 3 or 4 sections. Basically, in the first section, I have introduced you with different definitions, and then in second part, I have introduced you with different orders, how we interpret first order, zero order for different ADME cases. And then now we have to move to another section, which is model and compartments. Now, what are these models and what are these compartments? Basically, absorption, distribution, and metabolism and elimination is a very complex concept. Therefore, we and doing mathematics is also very difficult. So we assume something. What we assume? We assume first of all, I think I should tell you about pharmacokinetic models. What is pharmacokinetic model? It is a mathematical description through which we will quantify absorption, distribution, metabolism, and elimination. Basically, these are the mathematical formulas, mathematical description due to which through which we will quantify how much drug is present in your blood, how much it will eliminate. Then this is called pharmacokinetic model. And what is basically and to calculate all these things, we assume body into some compartment. And in this slides and in clinically, basically, we are interested in two models. One is called one compartment model and other is called two compartment model. Because there are some drugs which are hydrophilic in nature. Uh, so in these drugs, for example, I forget the example of one compartment model drug. I will tell you in a minute. So there are some drugs which follow one compartment model mechanics. What is one compartment mechanics? Model mechanics is basically in this model we assume that whole of our body is one compartment, and we you just need to understand that there is a glass of water, and you are pouring Panadol or aspirin in that glass of water. Then it will be a one compartment thing. So similarly, there are some drugs like warfarin. Yeah, I have recalled. Like for example, warfarin. Warfarin is is a kind of a drug which gets bound with your blood plasma protein. It is not extensively distributed, so it follows one compartment model. Similarly, there are some drugs which instantaneous or spontaneously distributed throughout the body. So they are also follow one compartment model. For these drugs, whole of the body works as a single compartment, as a single glass, basically. So you have to memorize all the drugs which get bound to the plasma protein. They follow this one compartment model mechanics, and in if a drug which have very immediate distribution, it will follow one compartment model. So this is the one compartment model elimination reaction. You have to memorize this formula, and we will use this formula as well. So if you have to find out the concentration of any drug at any point of time, what you have to do is we have to multiply initial concentration with exponent of minus k. K is basically the elimination constant, and I will tell you the formula of elimination constant in a bit, and T is the time. What this means is, let me explain it in this slide as well. In this slide, and I will explain it later on as well. For example, you are trying to measure the concentration of vancomycin, for example. So what you will do is you basically you have administered but how we administer vancomycin? We basically give a 1 hour infusion of vancomycin, and let's suppose your physician has asked you, or the pharmacist has asked you to take the peak level. So what the nurse will gonna do is he or she will take the sample after 1 hour. So, for example, you have started the infusion 8 o'clock in the morning. So, but your nurse will gonna take the sample at 10 o'clock in the morning. So, what will how uh, this equation will help you? So, for example, you have to calculate how much drug will be present on 12 o'clock or 11 on 13 o'clock. It means one in the noon. So you will use this formula. This formula will help you how much drug will be present in this specific point of time. So this is one compartment model. For this one compartment, all the drugs which do not have extensive distribution or get instantaneously distributed in the blood, they all follow one compartment model, and they have first order elimination as well. So for all the drugs which follow first order one compartment model, you have to use this formula. It means volume of distribution is equal to dose divided by concentration, and this is the second formula, that volume of distribution is equal to clearance multiplied by elimination constant. So, and I have explained you volume distribution as well. Just you have to memorize this formula, and then this is elimination rate constant, and this is a really important formula that you have to calculate elimination constant as well. Uh, Now, what we do for most of the drugs like vancomycin, we usually take two samples. One is peak sample, peak level, and other is trough sample. I will explain this in later slides as well. So what we do is we basically put all the concentration of whatever concentration we have got from the lab, we put it in the denominator and take the natural log and then minus it, and we put the time in the denominator basically, na? And then calculate the elimination rate constant. We will do this calculation in later slides. So as a recap, I should just have to for a recap or a small recap of what I have told you. I have told you there are some drugs which follow one compartment model, and then for these drugs we have to sometimes we have to calculate the concentration, and sometimes we have to calculate the volume of distribution, and sometimes we have to calculate the elimination rate constant. So you have to memorize all these three formulas. Yeah, they are really important. But there are many drugs like vancomycin, which follow two compartment model. So this is okay. Now this slide will help me elaborate two compartment model. Now, what is two compartment model? Any drug which have a volume of distribution, and there are all the drugs, like 90% of the drugs, they are not instantaneously distributed, or they get stuck with the albumin. There are many drugs which have a distribution phase. So any drug which have a distribution phase will follow a two compartment model, like vancomycin, like gentamicin. There are many antibiotics and other drugs. They all follow the two compartment model. So let me make it easy for you. All the drugs which do not have significant distribution phase will follow a one compartment model, and all the drugs which have basically an extensive distribution phase will have a two compartment model. And unlike one, as I've written here over here as well, that unlike one compartment model, many drugs distribute into body tissue at different rates. So what we do in this model, we basically suppose that the whole body is divided into two compartments. One is the central compartment, which is your blood, plasma, heart, and lungs, and other is your peripheral compartment, which is your your tissues, your muscles, or the site of action is your peripheral compartment. So what we assume is you administer the drug. Sorry, what's happening? Yeah. So you administer the drug into the central compartment. It stays in the central compartment, start distributing to the peripheral compartment, and then in initially obviously the distribution is more because it rely on diffusion. The more drug is present in your blood plasma, so the more it will goes to their peripheral compartment like tissues or site of action. Therefore, there is a different elimination rate constant as well uh, in the beginning. But after 5 half lives, obviously, the concentration on the central compartment and in the peripheral compartment will balance out. So there will be different elimination rate constant later on. Therefore, all these drugs which follow two compartment models, they basically have this kind of graph. And you can see initially there is less concentration in the blood because we always take sample from the blood. So in distribution phase, if you can see, there the flow is curved, and but later on it follows the one compartment model kinetics. So this is written over here as well, that there is a central compartment which includes the blood, heart, lungs, liver, and kidney, which are highly perfused organs, and the peripheral compartments are the skeletal muscles, bones, and the skin. And I have told you as well, there will be different elimination constant for all these phases. And uh, the volume of distribution in the central compartment we denote it with VC, and for peripheral compartment we denote it with VP. Now, the formula for concentration is also different for two compartment model, but you do not have to worry about this formula because we usually do not use clinically in clinical practice we usually do not use this formula. uh, but let me explain it because most of the many pharmacists work in clinical trial industry. They basically use this formula. And what is this? This formula, this is the formula for concentration if you have to determine the concentration of any drug at any point of time, then what you have to do is you have to plus the whatever the concentration is present in the distribution phase with whatever drug is present in the elimination phase. One more thing, we have some infusion pump present in our like in our OT or like in our ICU. These infusion pump basically calculate the concentration through this formula. They have this integrated system in their in that infusion pump, so they gave us the concentration because in these like machines or in these certain conditions, we are more concerned about. For example, you are if you are administering fentanyl to any patient, it has a lot of toxic effect. For example, it can make a patient drowsy, so we are more concerned about the concentration for that patient. But that machine usually give us the concentration through this formula. So now what we do is, so this is not clinically important, but this is, and this is the same formula. So what we do is basically, because the calculation of two compartment model is very difficult. So for example, vancomycin, we use the formulas of first order kinetics, but we do, because as a pharmacist we do know that the vancomycin will follow a two compartment model. It has a distribution phase and it will have an elimination phase. So whenever we ask our nurse to take the sample for therapeutic drug monitoring, we ask her not to take the drug. Like if you are, for example, if you are administering a drug at 8 o'clock in morning, we will ask a nurse to take the sample of the patient after 10, because we know uh, if you are administering a drug at 8 o'clock, the distribution phase will last for 2 hours for the vancomycin. Therefore, we will ask our nurse not to take the sample of the patient for the consideration uh, for 2 hours for the vancomycin, because we are interested in the elimination phase. So we will apply the same formula of which I have shown you in the first order kinetics as well. That you have to take the two concentrations, and then you have to take the natural log and you have to divide it with the time. So this is the same thing I have described you. Okay, time is very important. We know for vancomycin, you do not have to take the sample for 2 hours if you are administering a drug, and for digoxin, you do not have to take the sample of for concentration for like 6 to 8 hours. So okay, this is not important. Now one more thing, for two compartment model, there are three types of, yeah, three volume of distribution. One is central compartment. The volume of distribution which is calculated for central compartment will be different, and it for now let me make it easy for you. Uh, what we do is we all know that we cannot determine the concentration of drug on the site of action. What we do is what we can do is simply take the blood and determine the concentration of drug in the blood. So then we have to realize there are three instances when a drug which is highly distributable, which have high volume of distribution, there must be three instances for that drug. One, when you have administered a drug, then it will be more on like in the blood in your plasma. Then it will be called as the central compartment volume. But I mean, initially when you have administered a drug and it is not distributed, then the volume distribution will be called as central compartment volume. However, after some time, when it gets distributed, then there will be less volume of distribution. There will be less volume in, obviously, in the blood. It will distributed in the plasma. So then it will be called as volume in the peripheral compartment. And then after 4 to 5 half-life, the steady state concentration will be maintained. Then the volume distribution will be called as the volume of distribution state at steady state. So there are three types of volume of distribution for two compartment model. And this is not important. Basically, we do not use these formula for in our clinical practice. Yes, we do need to know, but we use this formula because usually whenever we have to calculate volume of distribution, we usually uh, uh, take when a steady state concentration is established. So we use this formula. This is the same formula we have discussed in the first order single model compartment, that volume distribution is equal to clearance divided by elimination rate constant. For two compartment model, it will become beta because it is the same thing, but we have denoted elimination rate constant with beta. So the formulas are the same. Just for a small recap, so there are drugs which follow one compartment model, and there are drugs which are two compartment model. But we usually in clinical practice we usually use the one compartment model. Just take an assumption that we whenever we take concentration of the blood drug, we ask our nurse not to take the sample of the patient when drug is distributing. We ask the nurse for, like, for vancomycin, we ask her to take the concentration, take the sample after 2 hours of infusion. So we can apply the same formula of one compartment model for clinical kinetics. So I know this is this is now. I think we should move to the calculation because we have started a little late due to some problem the with the link. So I'm skipping. Now, what is loading dose? Loading dose, whatever I have discussed in these slides, we have discussed it because we want to know the loading dose, we want to know the maintenance dose, and we want to know how much we have to adjust the drug. So this formula is also important. That loading dose depends on volume of distribution and steady state concentration. So if you have to calculate loading dose, you have to multiply the concentration you want to achieve with the volume of distribution. And one more thing, if a drug is administered orally, you have to divide it with bioavailability. And there are some drugs which are in salt form, so you have to divide with their salt as well. For example, colectin is present with cholestyramine sodium. Phenytoin is present with sodium pentanoate or pentanoic acid. So the formula will be different for these drugs. Otherwise, it will be loading dose, divide, whatever concentration you want to maintain, multiply volume of distribution. For oral dose, you have to divide by availability, and if it is in the salt form, you have to divide with the salt form as well. So this is the formula. As I've told you, loading dose will be the target concentration you have to achieve, multiple volume of distribution. Then you have to divide. S is for the salt form, and F is for the bioavailability. And this is important for the exam, that loading dose only governed by volume of distribution, and maintenance dose is governed by clearance. And why it is clinically important? So, for example, a patient has some renal problem or hepatic impairment maybe. We usually do not recommend our doctors to lower the loading dose. For example, colistin, or for example, vancomycin, for example, piperacillin tazobactam, which is come with the brand name of Tanzo, or peptaz. All these drugs are excreted through kidney, and if you have some kidney or renal impairment, uh, so we have to adjust the maintenance dose of these drugs. But what about the loading dose? We do not recommend to adjust the loading dose because we know loading dose does not depend upon the clearance. It only depends upon the volume of distribution, as I've told you, and the target concentration which you have which you want to achieve. So clinically, you have to remember or memorize it, that you do not have to adjust the loading dose if a patient have renal impairment or hepatic impairment. Yeah, but if it has some problem with the renal with kidney or liver, and the drug will have to exceed out with the kidney or the liver, you have to adjust the maintenance dose. You can adjust interval, or you can decrease the dose as well. So it is written over here as well. So yeah, sometimes we administer patient uh, multiple doses. Obviously, let's say if you are giving a patient oral drug, so we give 2 times daily or 3 times daily, and so on. But sometimes we give an IV infusion as well. So there are things which are important, because if you are giving a patient a continuous IV infusion, there will be not many peaks and troughs present in patient's blood plasma. But if you are giving a patient a multiple dose regimen or intermittent dose regimen, then there will be many fluctuation in his plasma. So this is clinically important. I'm skipping. Okay. Now the last part of this, then we will go to the calculation. Clearance, I have already told you, clearance is basically the amount of blood or the volume of the blood which get cleared from the drug is called clearance, and it depends upon the volume of distribution and the rate constant, elimination constant. And there is another formula of clearance as well. I think we should move to uh, now. Now we are moving to the moving to our formulas, and then we will see some numericals. These are the formulas which are clinically really important. Like we have to calculate the elimination rate constant. We sometimes we have to calculate the half life of the drugs as well. So these are the formula for elimination rate constant and elimination half life, and these are very important for exams as well. And we are also interested in calculating volume of distribution, and which is dose over concentration, and for sometimes we use clearance into elimination rate constant as well. And this is the formula of total body clearance. Clearance is equal to elimination rate constant multiplied by volume of distribution. So now move to the, so for example, if in an exam you have been given this question, that there is a 70 kg male patient who received 500 mg IV bolus of an suppose an antibiotic, and you have drawn a sample at 2 hour and 8 hours post infection, and the plasma concentration you have received is 15 mg and 3.75 mg per liter. So what will be the elimination rate constant then? So I have told you about elimination rate constant. What you have to do is you have to take the natural log of concentration and divide with the R, and your answer will be R inverse. Okay. And then similarly, if you have to take, if you want to calculate the half life, you just need to divide 0.693 with the elimination rate constant. And this is, I have told you in previous slides as well. And then that we are interested in initial concentration as well. So whatever time you have made, for example, I have told you that the patient, he was 70 kg patient, and we have taken sample at 2 hours. So you can see that we have put the concentration E, and the elimination rate constant was 0.231, and we have multiplied it with 2 because we have taken the at 2 hours. And then for volume distribution, you have to divide those with the concentration, and clearance will be K into VD. Now move to uh, the vancomycin. Yeah, this is really important. This is clinically very important. Basically, historically, when I have started my career, whenever any infectious disease consultant asks us to adjust the dose of vancomycin, we usually see the trough level, and we usually recommend based on the trough level. Now, ASHP guidelines have been changed. They have asked us not to see the trough level, They have a lot of researches on that thing, and they have got to know that if you adjust the drug with the trough level, uh, you may harm the patient. There will be more nephrotoxicity. You can check it. You can check the researches as well. Now, the guidelines suggest that you have to calculate area under curve, which I have explained to you as well. I have told you area under curve is uh, the curve is the concentration multiplied by time. The amount which is present in your blood in a specific amount of time is called area under curve. So what now uh, ASHB guidelines suggest us? They ask us to calculate area under curve for 24 hours and divide it by with minimum inhibitory concentration of antibiotic, and in this case, vancomycin. Uh, Let me tell you one more thing. It is same for gentamicin as well, and other there are many drugs as well. Right now, I can only recall vancomycin and gentamicin. So what you need to do is whenever your doctor or your infectious disease consultant asks you to adjust the dose of vancomycin, you have to calculate area under curve for 24 hours and divide it with minimum inhibitory concentration. And you have to memorize it that the value should be 400 to 600 mg per hour. And if it is less than 400, then you have to increase the dose. And if it is more than 600, then you have to decrease the dose, or you can change the interval as well. So, yeah, historically it was a tough target, but now the area under curve should be less than 600 per hour. Take a 400 to 600 it should be. So this is the scenario. So, for example, if you have a patient which have a 65, which have age 65-year-old and 70 kg is his weight, and you are giving vancomycin 1 gram BD, which is the normally dose of the vancomycin, and we usually give vancomycin over 1 hour because if you give vancomycin as a bolus, there will be more chance of getting Redmond syndrome. Uh, Although I have to explain all these things, I have included this thing in my slides, but I have skipped this part. Why we administer vancomycin on over 1 hour? Uh, those who really want to understand this thing, they can go through my slides and will understand this well as well. But now, right now, this is not my right now this is not my topic. So back to our topic that, for example, you have a patient which is 65-year-old and he's 70 kg, and he is given with 1 gram BD, and your doctor has asked you, your infectious disease consultant has asked you to, let's say, जो है, adjust the dose of vancomycin. So what you do is you usually when we prescribe, or whenever our infectious disease consultant prescribe vancomycin, he also have he also have report of culture and sensitivity. So, for example, he has the report of culture and sensitivity, and we do know that for MRSA, the minimum inhibitory concentration is 1 mg per liter of vancomycin. So, what we do, and the nurse has taken, for example, has taken the blood sample, and as I have told you, you have to ask first of all, as a pharmacist, we ask a nurse, for example, if she has administered the drug at 8 hours at 8 o'clock, and we will ask our nurse to take the sample at 10 o'clock in the morning. So there will be 2 hour gap. So that whatever dose she has administered at 8 o'clock get distributed in the peripheral compartment, and then it will give us the peak concentration. Please keep remember this thing. Memorize this thing as well, that whenever you take the drug sample after administering the drug, it will give you the peak concentration. So, for example, you get the concentration. It is not really the peak concentration. It will be the C1 for us. And why I have said it is not peak concentration, although it is, you will get to understand in the next slide. Uh, so, for example, she has drawn the sample after administering at 8 o'clock, and then she has get the sample at 10 o'clock, and the concentration comes out with 30 mg per liter. Similarly, the trough level she has taken. So, for example, we have to administer 1 gram BD. So, first dose we will administer at 8 o'clock, and other dose we will administer at night, say at 8 o'clock. we will ask our nurse to take the sample at 7 o'clock before administering the next dose, 1 hour before administering the next dose. So she has taken 11 hour post first dose, so it comes out at 10 mg per liter. So now back in 2016 when I have 14 sorry back in 2014 when I have started my career, whenever we see that, oh, this is 10 mg per liter, we ask our doctor to increase the dose or change the interval, but not today. Even though it comes out 10 mg per liter, now what we will gonna do? First of all, we will calculate the elimination rate constant. The next step we will do is we will determine what is the maximum concentration and what is the minimum concentration. And wait for a second, then you get to know why I have written maximum concentration and minimum concentration. Although I have tell you that we have taken C1 and C2, but instead we will determine Cmax and Cmin as well, and then we will determine area under curve. There is a formula for that, and then we will calculate 24-hour exposure, which is AUC 24. And you do not have to worry about all these things because there is a calculator available. We just have to put the dose. Usually, all our pharmacists which are working in my institute, they do not calculate all these things because this will be like a lengthy calculation. We have a calculator available. The site is called Clinical Calc, and you just need to write the weight of the patient, age of the patient, and the concentration you have got. It will do all the calculation for us and give us the formula. But yes, we do need to know the steps. So first step is you need to calculate the elimination rate constant. Then you have to calculate the maximum and minimum concentration. Then we will calculate area under curve for 12 hour because we are administering the patient the dose of 12 hour with 12-hour interval, and then we will calculate AUC 24. So this is the formula of elimination rate constant, and you can see this is same as the first order kinetics as well. The basic difference is we have taken the sample in the elimination phase. The formula is same. You have to take the natural log of C1 divided by C2, and then you have to write the dose, write the time interval. So we have taken at 11 hour and 2 hours. So we will write it over here, and then we will calculate maximum and minimum concentration. So now what we have done over here. So you have to recall that I have asked you, and I have asked your nurse that if you have administered a dose at 8 o'clock, then you have to administer, then you have to take the concentration at 10 o'clock. So she has taken the sample after 2 hour interval. So it is not the maximum concentration. Maximum concentration will be when the infusion, all the vancomycin you have administered to the patient. So it will be right at, like, if you have started your infusion at 8 o'clock and you have infused at 9 o'clock, then at the very moment at 9 o'clock there will be a maximum concentration. But we cannot and we should not draw the sample at 9 o'clock. Why? Because we know pharmacologically that at that point of instant, the drug will be distributing into the peripheral compartment. Therefore, we will use this formula to, to theoretically know the concentration, the maximum concentration. Similarly, when will be the minimum concentration? Minimum concentration will be right before you are administering the second dose. So in the same way, we will ask our nurse, or obviously this is not practically possible that your nurse will gonna take the drug at like she will be busy obviously. So it may happen that she will have taken the sample at 10 hour or like 11 hours. So you can use this formula to exactly know the minimum concentration right at before administering the next dose. So these formulas are very important in that case. Then what you do is for obviously I have told you vancomycin is a drug which follow two compartment model. So obviously there will be two distinct value for area under curve. One when the drug is distributing and the other when the drug is eliminating. So for distribution, what you will do, you will plus the maximum and minimum concentration and divide it with 2. And for elimination, you will minus maximum and minimum concentration divide with K. So these are the area under curve, and its unit is R per liter, and then you will plus these uh, these values, and you will get area under curve for 12-hour interval. Because our drug was we were administering the drug at 12-hour interval, then we will call it AUC 12. If we were administering it like 6 hours interval, then we will say it AUC 6. Then what you have to do, because you in 24 hours you will administer the drug 2 times, you have to multiply this value with 2, and then you will then we have got this answer 453. Now this is very important. So now if you can recall, the trough level was basically uh, if I can show you here. I know this is difficult. The trough level was 10. So previously in 2016, uh, it was really easy for us just to ask the doctor to adjust the dose. But now you can see the values like 453, and it's in the range of 400 and 600. I have told you. Now the for AUC 24 and with MIC is 400 over 400 to 600. We will ask our doctor not to adjust the dose of vancomycin. So this is how we usually adjust our doses, and these are the pharmacokinetic parameters which are clinically really important for us to administer dose. So thank you so much, and I'm very sorry there was some problem in the beginning. Uh, so if you have any question, you can ask me. There are some people who have contacted us from Philippines. They have requested us uh, to deliver this lecture in English. Uh, Otherwise, in first two lectures were in Urdu. I hope if you have any question, you can ask me. I know this is this was very extensive, but I have tried my level best to deliver all the important things. So if you have any questions, you can ask me, please. Otherwise, we can end the call.